Cartwright.
My lady, could Mr. Hancock please stand whilst he's sworn? Thank you.
Thank you. I do solemnly, sincerely and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
Mr. Hancock, thank you for coming back. I do understand how difficult it must be for you to keep coming back, and I do appreciate your continued help.
Thank you. Could you please tell the inquiry your full name?
Yes, I'm Matthew John David Hancock.
Mr. Hancock, can I firstly thank you on behalf of Module 7 for the provision of your 9th witness statement. If that could be displayed, please. INQ 587294. And if we could move, please, to page 96, where we see it's dated the 7th of April 2025. And can I ask you to confirm are the contents of that statement true to the best of your knowledge and belief?
Yes, of course.
Thank you. Mr. Hancock, that statement will be published, so the full context of the additional evidence you've given in respect of Module 7 will be available, because I appreciate today there'll be topics we can cover, but the full detail you've provided is set out within that statement.
Yeah.
Thank you. Now, Mr. Hancock, having identified that you've given now 9 witness statements, it's right also that you have now given evidence to every one of the modules to date in the inquiry.
So far?
And in making that point, I just want to make perhaps what's an obvious point, that it's right, isn't it? Today we're going to be dealing with test, trace and isolate. But when we consider those issues in focus today, the full context is that you had essentially a portfolio that covered many areas that this inquiry has been examining. And I think you're particularly anxious that the full context of your work during the pandemic is not forgotten.
Well, it's more that when considering lessons for the future, it's important not to take each module in isolation. I understand why it's been looked at in isolation, each one, but because all of these decisions, in fact, in reality, run concurrently, and you go from a meeting on test, trace and isolate to a meeting on getting the vaccine going to a meeting on non-pharmaceutical interventions, and there is an interaction between them all.
Thank you. Well, let's then just identify who you are and the roles you're performing for the context. And again, it's right, isn't it, that from July of 2018, you were Secretary of State for Health and Social Care.
Yes.
And I think the full detail of your portfolio before that time is within your witness statement. Is there anything else you'd wish to say about your previous knowledge and experience that's going to be relevant to the topics we're going to deal with today?
Not over and above what's in the written statement.
Thank you. Can I then start with the first topic, please, of preparedness, and preparedness in the context of test, trace and isolate?
Yes. And
to do that, can we go, please, to your paragraph 62, which is at page 20? Thank you. Now, you've given a section of your statement over to assist with your views on preparedness and capacity in the context of test, trace and isolate. You detail that you reiterate the concerns you set out in respect to the weaknesses in preparedness and capacity for testing and tracing in an earlier statement. And please, if you could display the next paragraph. You say the UK's flawed doctrine had consequences that led to weaknesses in our readiness for a pandemic because of the wrong attitude and because of operational weaknesses.
Yes.
And then in the next paragraph again, please. In respect of both testing and contact tracing, there was no capacity for expansion to industrial scale. We had to build both.
Yes.
And so, before we get into the detail, can I ask you first of all, from the perspective of the relevant minister with the relevant responsibility, can you give your perspective of January 2020 of the readiness and preparedness relating to, first of all, testing?
Well, I'm really glad that you've come to this first. And if this module of the inquiry is to conclude anything, I think it is absolutely critical that it concludes on this point. The doctrine that we had going into the pandemic that was shared by most of the Western world and the World Health Organization was wrong, because it essentially dealt with how to cope with a pandemic as it affected the whole country, the whole community, the whole human race, and did not address the need to stop a pandemic from infecting everybody. And we dealt with that in module 1, where I set that out in more detail. That had 2 huge consequences here. The first is that there was a view in the public health community that, and the advice I received, therefore, from Public Health England, that we should not need or try to test at scale or contact trace at scale. And as soon as there was community-based transmission, there was no point in testing and contact tracing any further outside of hospitals because effectively everybody was going to get infected. That was the wrong attitude, and it is absolutely critical that next time there's a pandemic, because there will be a next time, we are ready to take the actions to stop it spreading and protect the most vulnerable first. Second, operational weakness. PHE was brilliant at the early science and at turning the viral sequence that the Chinese published in mid-January into a test within 3 or 4 days. They proved entirely incapable of expanding that testing capacity. In their defence, they'd never expected to because of the wrong attitude. And when the existing UK system, which is essentially a cottage industry of testing in little centres, in whether that's in hospitals or in academic institutes like the Crick Institute, or if it's in PHE labs, the ability to expand those at the colossal scale that was needed, not just double or triple the output, but multiply it by 1,000 or 100,000 times, that was simply not there. And I think it's highly likely we'll get onto this decentralisation versus centralisation point. The critical thing is that we absolutely must, as a nation, be ready to expand, radically expand testing capacity once a test is developed. We were not last time. I had to do that. There are critics who said that it was done in the wrong way. What matters is that it's done, and it's planned for next time to be ready to be done.
Thank you. Mr. Hancock, then, can we put some context on the answer you've just given, but particularly to understand what seems to be where you've identified PHE were doing a good job when the test and the assay was there, but there came a time where you had concerns about the ability of PHE to have the resources or capabilities or expertise to scale up?
Yes, it wasn't about resources, it was about capability. They were good at the science, and there were lots of good science organisations, but the difference between a scientific scale testing capacity and an industrial scale testing capacity is vast, and it's a different capability, building a huge system with thousands of people compared to having scientists pipetting. And if I just illustrate this with one story, okay. I went to one of these labs in either late February or early March.
And just pausing there, this is a PHE laboratory.
I went to a PHE laboratory,
in your statement.
and there were I was taken into a science lab, and because I'd asked to see their testing facility, and they took me into a side room that was about the size of your desk, my lady, and it had 2 people in scientific overcoats, working very hard, no criticism of them whatsoever, to hand pipette samples in order to do the tests on this lab bench. And they were very proud because they doubled their capacity. And I'm grateful for them doubling their capacity, but it was woefully inadequate. It was a cottage industry, and we needed an industrial scale capacity. And crucially, next time, we need to move as fast as possible to an industrial scale capacity.
Thank you. Well, Mr. Hancock, for context of the answer you've just given, the PHE assay was used at the PHE Collingdale laboratory to diagnose the first case in England on the 31st of January 2020. That PHE was able to isolate and grow the SARS-CoV-2 virus from the first UK diagnosed case, which was then rolled out to 12 PHE labs across the United Kingdom on the 10th of February 2020. And then can I ask you, because we know then the containment level to handle the virus was reduced from a level 3 to a level 2 on the 13th of February 2020. Can I ask you then, we know that on the 17th of March, you essentially took over responsibility for testing from PHE.
Yeah.
And can you give us some idea then as to when it was you realised that you had to take more control over testing for the scale-up that was needed?
Well, I took that decision on the 17th of March in that meeting, but the history of that is actually both better and worse than you describe. Better is that even before we had a case in the UK, PHE had developed a test after the Chinese had published the viral sequence of the virus. So their science was brilliant. That was before even there was a case in the UK. So they'd done incredibly well at that. And that gave me confidence that what they were telling me in their capacity to build a testing system was good. So I started out with a high regard for PHE's capacity in this area, in the middle of January. And from the end of January, when it became clear that this was likely to become a global pandemic, and from mid-January to the end of January, it went from 50-50 to almost certain. I insisted on ramping up the testing capacity. Told PHE they had whatever resources they needed. But I also wanted them to engage every testing capacity in the country. And despite my repeated insistence, they would not share the serum samples. They would not engage with the private sector companies that had the capacity to develop these tests. And that was a mistake, and it was deeply frustrating because I kept asking them to, and they didn't. And the view was, we need to keep expanding the PHE labs, the NHS labs, the university capability in this area. And that argument was put to me over and over again during February and the first half of March, and I became increasingly frustrated at the slow growth. And then we organised...
Mr. Hancock, I apologise to interrupt you.
Yeah.
We're going to deal with scale-up, but I want to sort of deal with preparedness, and then please, you will get given an opportunity to provide details of the scale-up, please.
No problem. So the concluding sentence of that answer, if you like, is that I wasn't the only one with this frustration, and Number 10 organised a meeting on the 17th of March to bring things to a head.
Now, can I, in answering that question, you've just referenced that PHE wouldn't share the assay, but in fact, the assay was shared, so it was available to non-PHE laboratories from the February.
But not the private sector. So there were a number of private sector organisations that were able to help and could not get hold of of what they needed to develop a test.
Well, let's revisit that when we deal with scale-up, because what you've highlighted as cottage industry laboratories, I want to explore with you the alternative option that provided.
Yes.
So we'll come to that in a moment. But
okay.
So you've given your overview on preparedness linked to testing, but the paragraph we looked at together, if we can just display again your paragraph 64, I would now like just to capture, and again, we're going to deal with the chronology, so please don't think you have to address it all in answering this question. I'd just like to capture your understanding about the question of preparedness by reference to contact tracing.
Yeah.
And perhaps can I just add a little bit of extra detail on that to understand. Did you appreciate that the directors of public health within local authorities discharged and performed the role of contact tracing? So not just PHE, but there was this resource in every local authority across the United Kingdom that had the resources. Appreciated that in Northern Ireland there was just a single director of public health.
You've answered the question really. Of course I appreciated that. There was one person in each of the upper tier local authorities, and therefore around 100 people. It was they're brilliant people. I engaged with a huge number of them throughout the pandemic. But the idea that they alone could have solved this problem was unfortunately the wrong attitude and led to operational weakness, as the previous paragraph says.
So from your perspective, you're saying when the pandemic was coming in and rolling from January onwards, you appreciated the PHE contact tracing capacity, but also the capacity that existed in directors of public health.
Of course I did, yeah. That was the capacity that we had at the time. It was wholly inadequate.
And that's those. Can I then capture your views as to why you say the contact tracing from a preparedness perspective was flawed?
It was flawed because there was a reliance on a small number of people doing high quality contact tracing, typically for localized outbreaks like of Legionnaire's disease, for instance, and they were really good at that. What they were not organized for, and it wasn't the fault of any individual, what they weren't organized for was a national scale, indeed a global scale catastrophe, and the scale that is needed to respond to that. Now, eventually where we got to was a merger of a national system and local system, which is, in my view, the best system you can have. But the idea you could just do it with what we had at the start, which was the PHE view, was wrong.
Thank you. Can I then, with you just dealing with the fact that it was then right to go to a mixed system, just deal with that topic now? It may save us time as we go through the chronology. We know that when you scaled up your contact tracing, and certainly from the 18th of March when you moved to the national testing programme and the strategies that you implemented, I think the phrase is used about starting contact tracing from scratch.
Yes.
And obviously at that point there were the large numbers of individuals that were hired and recruited to work in the call centres.
Yeah.
And so certainly the strategy appears to have then been without input from local authorities and Public Health England. And so can you assist as to why then it had this period where you were not utilising the expertise and skills of local authority and solely basing your strategy at that point in time? I think before then it moved again back to needing the local, of just on call centre contact tracers in a central location that do not have those local connections with their community.
So that isn't quite what happened. PHE, of course, infamously turned off the contact tracing system, and that was wrong and a mistake. They were, of course, involved in the development of a national contact tracing system, but we found it hard at first to integrate the national and the local. There were all sorts of data transfer issues that should be sorted out in advance. There were essentially the integration of a system where you have a national system doing essentially the easy mass repeat cases, and then the local capability delivering the hard to reach cases. That is where we got to and is what we should seek for next time. But this brings us back to the original context. There was one leader of public health per council, and they were busy because they were doing everything else as well. So the idea...
I don't think that's the position across local authorities. Certainly in Northern Ireland they had one director of public health, but that's not representative across the resources in other local authorities.
I think it's worth checking exactly how many there were, but there was one lead public health official in each local authority, and they had to do, like I had to do, all the other things. They had to do non-pharmaceutical interventions. They had to do preparation for vaccine delivery. They had to do they were involved in PPE, which is obviously absolutely critical at this time. They were involved right across the board. The idea that you could use just the local groups to deliver this is wrong. And we did succeed eventually in getting a decent synthesis between the national system and the local system. That is what we should seek next time. We did have to start from scratch because PHE had stopped its contact tracing, but the PHE contact tracing capability, it, of course, informed, and many individuals were involved in building the national system. What we couldn't do was base the new national system on the technology used for under the micro outbreak PHE system, because the technology simply wasn't capable of transferring from one to the other. We had to build that from scratch.
And then whilst we deal again with the contact tracers and the numbers recruited, I think we see it in the strategies of 20,000 have been identified as being necessary.
Yeah.
I think you're probably aware, Mr. Hancock, that Lord Agnew in particular in Module 5 was highly critical of the volume of contact tracers that had been recruited, that he gave his view as to how much they were utilised. And so can I ask you, where did you get the 20,000 figure necessary for in the call centres for contact tracing?
I don't recall there will have been somebody would have made an estimate based on a piece of advice, but you've got to remember this is the first time that this has happened in living memory, so it inevitably was an estimate. It's perfectly reasonable with hindsight to criticise the efficiency of these things, but it was better to have them than not, and we had to have a sense of the scale.
Thank you. And so, Mr. Hancock, again, if we use the example of the helpful technical advice that the CMOs and the chief scientific officers have given to essentially assist future individuals that end up in a role.
Yeah.
I think you really want to share your experience as a minister, the relevant minister, Secretary of State, as to playbooks for future pandemics. And so is your first headline from what you've said is for contact tracing, it essentially in a pandemic needs a combination of the local skills but also a centralised contact tracers as well.
Yes.
Thank you.
And critically, the data structures to allow that integration to work.
Thank you. Now, can I just on preparedness ask you a follow-up question, please? Can you assist us with what contingency plans and framework were already in place to ensure that the TTI could be implemented equitably across all population groups, including minority ethnic communities, in January 2020, please? The whole purpose of contact tracing is to try to protect those who are most vulnerable to catching the virus. And therefore, it's vital that contact tracing, to be done well, is understood and the messages are received by those who are being contacted. It's not what you say, it's what people hear. So therefore, it's vital that the contact tracing happens in such a way as those who are being contacted will act upon the advice that they're given. So naturally, it's critical that this takes into account the diversity of communities that are being contacted. So that was at the front of our minds from when I got involved in the contact tracing system around the time that PHE decided to close it. Thank you. And then can I ask additionally then, please, on this issue of preparedness, were there structural limitations within Public Health England or the Department of Health and Social Care that hindered a rapid and equitable scale-up of test, trace and isolate in the early months of the pandemic?
Yes, PHE didn't have the operational capacity to scale.
Thank you. Now, in giving your first headline recommendation around that needs to be a mix of local and national contact tracers, you referenced also data.
Yeah.
And the inquiry's already heard quite a bit of evidence around data blockages that have been referenced to the Department of Health and Social Care.
Yeah.
We'll be hearing from the corporate witness to speak on behalf of the Department of Health and Social Care next week.
Yeah.
But I wonder whether you can assist from your perspective.
Yeah.
So the inquiry's heard lots of evidence about different data systems not essentially operating interoperably in terms of, particularly where it was patient details. So the Lighthouse laboratories, for example, they didn't. There had to be systems to make sure that the results could be shared.
Yeah.
We've heard from the National Police Chiefs Council that he was pushing for data from the Department of Health and Social Care that he needed.
Yeah.
That was never forthcoming. And we've also heard about how even when there were pilots, such as the Liverpool pilot, where they needed access to the data on hospitalisation in that trial, that was not forthcoming for months and months. Yeah. And that data was hugely helpful when it arrived many months after to inform just how successful that trial had been.
Absolutely.
So is there any insight or assistance you can give around the issue of data blockages,
Yeah.
it seems to be a constant theme across the
Absolutely
different
constant. It was terrible. I personally dealt with a whole series of them to try to unblock these data blockages. Previously, I'd been the digital secretary and I'd taken the data sharing legislation through Parliament and indeed GDPR. So it's an area I know extremely well. And it was deeply frustrating at the lack of appropriate data sharing, which was for, in some cases, for technological reasons. But actually, there were far fewer blockages due to poor technology than due to over-officious and absurd, in some cases, data rules. All of this data was protected under GDPR. GDPR is a more than adequate protection of personal data. Health data is not special or different. It's just personal sensitive data. It needs to be treated with respect and it needs to be treated with sensitivity. Probably the single best thing that we did in this area was when we wrote NHSX. It was Matthew Gould who wrote a 2-page data protection rules for the NHS and the health system. You could get it on 2 pages. It was written intentionally so that the nurse on the ward could understand what could or couldn't be done. That broke through a huge amount of this legalistic and bureaucratic rubbish that got in the way of data sharing. I found it so frustrating because I'd taken through the legislation that allowed for data sharing and still persuading parts of the system that it was okay to share data in order to save lives was still a huge problem. Again, I come to a recommendation.
Thank you.
Since the pandemic, that 2-page set of rules about data sharing in the NHS has been once again replaced with an unbelievably unnecessary, complicated system. Personally, I would go back to the 2-pager. I had advice to remove it when I was still in office towards the end of the pandemic. I refused to. There is no excuse for the poor data sharing that we still find across the system. And if people can't even bring themselves to do the right thing in normal times, as they should now, at least if there's a pandemic, can we return to a free flow of protected data? This isn't about publishing it, it's about sharing it between those parts of the system that need it in order to save lives.
Thank you, Mr. Hancock. And again, we've heard similar evidence from the corporate witness, Mr. Garton, on behalf of what was the Department of Levelling Up, that efforts can be taken in peacetime to essentially create these policies and procedures to make data sharing work in a pandemic.
Yeah.
And it seems that you endorse that position.
Strongly, and keep it as simple as possible.
Thank you. Now, Mr. Hancock, I'm going to move next to a topic about asymptomatic transmission and
Sure.
testing. And I want to deal with this before we deal with the scaling up.
Okay.
Because I know you've been asked about it in other modules, but you will understand how it's particularly important in Module 7.
Absolutely.
Because I want there to be clarity, because the positions, there is some evidence that suggests that you may have not had the fullest understanding of asymptomatic transmission or the ability for a PCR test, even with someone with no symptoms,
Yeah.
to identify the positivity or infectivity.
Yeah.
And so can we start then, please, with your paragraph 202, please, where you tell us about your relevant evidence about asymptomatic testing. And then I want to particularly deal with some of the evidence we've had from Lord Vallance on his views on your understanding. So it's page 66, please, at paragraph 202. Thank you. You tell us that I've covered this subject extensively in my earlier statements, and again invite the inquiry to consider the statements of the Chief Medical Officer about asymptomatic transmission. As the CMO makes clear, it was a gradual process of accumulation of evidence that led to asymptomatic transmission being considered a major part of the force of transmission of the virus. I agree with the views set out by the Chief Medical Officer, which should not be surprising, as we discussed it regularly during this period.
Yeah.
And I'll crystallise what you say here and then we'll build on the topic, please. As I've explained above, the initial very clear scientific advice was not to test those without symptoms. I was told categorically by PHE that the tests would not work on people without symptoms. and that to test someone without symptoms would risk a false negative, i.e. someone incubating the virus could be given a negative test result. I was advised that this would be even more dangerous than not being tested, as it would give a false assurance.
Yes.
And then you go on to tell us about the WHO advice. And so can we build on this topic together? Because the inquiry has some evidence from Lord Vallance that I think you're aware of and is touched upon before, that indicates a timeline where he has indicated that you had a confusion about the efficacy of testing people without symptoms.
Yes.
And part of the chain that he relies upon, so it is essentially that SAGE's advice from the 28th of January of 2020 had recognised asymptomatic transmission.
Was a possibility.
And
They had not recognised asymptomatic transmission. That the difference between recognising that there was asymptomatic transmission and recognising that there was a possibility of asymptomatic transmission is absolutely at the heart of this challenge.
Thank you. Well, let's then move forward to the 11th of March, and I think we're going to look together at the WhatsApp exchange that took place about a public statement concerning the Prime Minister's contact with Nadine Dorries.
Yeah.
Obviously in the context of the positive case. And can we perhaps work through the messages which are said to be supportive from Lord Vallance's perspective of you not having that full understanding of asymptomatic testing being capable of being picked up on a PCR test?
Yes.
Can we please display INQ 000102697, and it's page 16 within that document I want to go to.
Okay.
That's 102697. Thank you. Now, if we can pick up, I think at the perhaps, in fact, can we go the page before,
Page
just to
before, yeah.
start the story at page 15, please? Thank you.
Oop.
Or
No,
maybe
it's
not.
not.
Let's go to page 16.
Well,
Thank you.
It's quite important, page 15.
Thank you. Well, Mr. Hancock, if there's further context that's assessed in a slower time as being relevant to Module 7, that will be disclosed. But I think we can capture the sense of this. So we can see, we follow the story. In this case, it's the contact tracing aspect that's key to who gets tested. Then we see, do we have a clear view on when Nadine first became symptomatic? My understanding is that she felt a little under the weather and so on. Then James Slack, who I think is your special advisor, is that correct?
No, Jamie and Jocko Goodwin was my special advisor. James Slack was the Director of Communications at 10 Downing Street.
And it says, final below, line on test not working, removed. Ray the PM on background. We follow the advice of Public Health England and the Chief Medical Officer. The PM has no symptoms, so there is no need for a test. The PM was not in close contact with Nadine Dorries. The advice is that you would have to be within 2 metres of someone for more than 15 minutes to pass it on. It's also worth restating the advice on washing hands, which the Prime Minister does regularly. And I think if we then follow that down, I think we get your entry at 10:28. Thank you, 10:28:17. So, Mr. Hancock MP, I'm content with this line. We clearly need to clear up the testing for non-symptomatic people. Having spoken to Chris Whitty and PHE people I'm with now, Patrick, what you've said is not right. The clinical advice I've had is that the test is not reliable on people without symptoms. The reason is that there are so many false negatives when there are no symptoms that testing is counterproductive. Can the scientists please clear this up urgently? And then if we follow that through, we see the conversation continues at the bottom of that page. And I don't know whether you want to speak us through this exchange, because it suggests we can then see Chris Whitty saying not reliable is correct. It can pick up some asymptomatic cases, but not advise.
Yeah.
You then say we cannot say this. She's told people she had symptoms on Thursday. We mustn't cover anything up.
That's about a different bit of the exchange.
Thank you. And then Mr. Whitty says, Patrick and I will do a joint note, not on WhatsApp, on testing. But again, it's right, isn't it? Mr. Vallance was effectively saying in this that it could detect. But tell us your interpretation.
Yeah, so
of this
there's
exchange.
two further things needed before we can address this. Over the page,
Thank you. Let's go to there now on page 17.
1047, Patrick Vallance, agree, not reliable, not does not work.
So let's just pause there.
Yeah. And for page 15, which isn't shown on here, or I won't read it out, but for context, number 10 had proposed a line saying testing does not work, and Chris Whitty had said okay, and Vallance had said not correct, that test does not work on people with no symptoms. So there was a disagreement of nuance between the two key scientific advisors, and it was resolved in this text exchange that they both agreed on the language which is that tests are not reliable, and for the reason that Chris Whitty had set out at 10:36 on this exchange. That was the position I had been advised. It was the position I understood. I had a full understanding of this throughout, and including as the scientific advice changed. But it was to give, this is totally reasonable that two scientific advisors might have a slightly different nuance in view in what was a area of huge uncertainty. But so what I did, which is the right thing to do, was I asked for formal scientific advice. Can the scientists please clear this up urgently? And Chris Whitty said, Patrick and I will do a joint note, not on WhatsApp, on testing. So I was therefore content. The line I'd been using, which is that testing isn't reliable, was agreed by Patrick and Chris, and I asked for a full note on to explain exactly what the position was, because there was clearly distinction between them on whether the exact nuance around this, and this phrase does not work, which is a colloquialism for is not reliable and shouldn't be used. And Patrick then did not raise this subject with me for another month, and so I continued to use the agreed position. And then a month later, on the 13th of April, the early morning of the 14th of April, Chris Whitty told me that their advice had changed, which was good. This was after some CDC work on asymptomatic testing. So I had a full understanding. I have subsequently discovered that Patrick now thinks that I was confused, but he didn't mention that at the time.
So plainly, what this exchange is capturing is what you've been a difference of opinion between the Chief Medical Officer and the Chief Scientific Advisor about a very important issue. Would you agree around the?
I think that's slightly overplaying it. It's a difference of nuance, because everybody agreed that all the advice to me from PHE, from CMO and CSA was that the tests were not reliable, and therefore shouldn't be used on people who were asymptomatic. That advice changed to me on the 14th of April. And I was, as you, if you care to look at them, can see in the text message around that time, when I got that news from Chris Whitty, I was delighted, because it meant that we could use tests reliably on asymptomatic people. Policy has to be based on scientific advice. It is harder as a decision maker when the scientific advice is not unanimous. But you have to work your way. You have to make a decision given all the information that you have. The further context I put into this is that throughout this period, until the middle of April, the formal PHE advice, scientific advice, was that asymptomatic testing was not reliable, and therefore it would have been very unusual for me to have overruled that scientific advice and said that, yes, they are reliable when your formal advice is that they're not.
Thank you. Mr. Hancock, obviously you've clarified the issue here is around whether the test is reliable for asymptomatic.
This is all about whether testing people without symptoms is reliable, yes.
And that's what I want to just be absolutely clear about. As of March of 2020, had you appreciated that the coronavirus was being transmitted, so asymptomatically?
Yeah, I had a big worry about that. But again, the clinical advice took a long time to conclude that that was happening. So in January 2020, I was very worried about asymptomatic transmission. This is irrespective of the testing of it. This is whether the virus could get from one person to another person if the person throwing off the virus didn't have symptoms. I spoke to my international counterparts. I spoke to the head of the WHO about this subject. I was very worried about it. The formal advice I was given was that the previous known coronaviruses that affect humans are not transmitted asymptomatically, and therefore we should assume that this one isn't either. But I kept challenging this advice all the way through this period. But the global consensus was that asymptomatic transmission was not proven, and that policy should be based on an assumption of no asymptomatic transmission. On the 2nd of April, the CDC published its first evidence of asymptomatic transmission, concrete evidence, and I acted on that immediately, and I formally got the advice again on the 14th of April that asymptomatic I got the advice from the CMO. I say the word formally because the PHE formal advice didn't change for another couple of weeks, but we started making government decisions based on an assumption of asymptomatic transmission from the 14th of April. So I was involved in this debate throughout. I understood the distinction between that there wasn't a yes or no answer to this question during this period. It was totally unknown globally. There's various people who have since said, well, I was saying that there was asymptomatic transmission. The key decision makers were discussing the issue of asymptomatic transmission, but the formal advice was that we should not base policy on an assumption of asymptomatic transmission.
Mr. Hancock, then, can I ask you, because a difference of approach, of understanding seems to be clear from this, when you've now told us, and we'll come to look at the text exchanges of the 14th of April,
yeah.
But was it not essential that you had clarity on that position?
But we didn't know. It was a global pandemic with a novel pathogen. So we didn't. You can see from this, Patrick and Chris disagreed on a nuance. We came to a view in this text exchange, which is not reliable. And Patrick there is confirming, agree, not reliable. And that was therefore the basis of policy until I was advised by them of a policy change a month later. But the thing that frustrates me looking back, and especially since I've been accused of being confused, which I obviously wasn't, and this text exchange demonstrates it, is that I asked for advice from Patrick on the 11th of March, and I received it on the 14th of April.
Mr. Hancock, can I explore with you then as to whether you thought to cast your net wider for the advice on this issue?
No, absolutely. I was talking to. I talked to Jens Spahn in Germany. I spoke to Roberto Speranza in Italy. I spoke to Tedros at the WHO. This was a subject which was much debated.
Can I
if I just finish my sentence, the challenge is, what do you base your policy on? And I had this problem that the formal advice was as it was. Until it changed. And you can, if you go to the text when I'm told on the 14th of April, it's INQ 0000933326. If I just finish, at 8:16 a.m., Chris Whitty has done, from me to my team, Chris Whitty has done an evidence review and now recommending testing of all going into care homes and segregation whilst awaiting results. This is obviously a good, positive step, and we must put it into the document, i.e. into policy.
Mr. Hancock, please don't worry at all. We will display the exchanges, and so
Sure.
it can be fully contextualised.
We'll get through it much quicker, Ms Hancock, if you trust Ms Cartwright. I
Right.
promise you. She knows what she's doing.
But what I'm going to consider you, because we're going to look as well at letters that were being sent to you from the Crick Institute.
Oh, yeah.
Now, the Crick were developing, they had developed their test.
Yeah.
And they were testing essentially on your doorstep in the London area. And they, when we're doing the testing in conjunction as part of the consortium, had identified very clearly on PCR tests that there was clear evidence of asymptomatic transmission that was being picked up on their PCR tests. And so,
What was the date of that?
well, we'll look at that together, and we'll look at the letter.
Okay.
And I think you had knowledge of the Crick's work, because in fact we'll look together at one of the documents, I think, that was published, where essentially the department was saying about the good things that the Crick was doing.
Yeah.
And so at any point after the 11th of March, did anyone give you any of the information as to what the Crick had identified, that they were picking up, that there was asymptomatic transmission on PCR tests?
There was a continued debate in this period, and my initial concern from January continued all the way through this period. I don't recall the specific pieces of evidence. If the letter you're referring to, well, maybe we should go to the letter.
Well, we'll go to the letter. What we'll do is can we just look then, please, together at the scaling up document where the work of the Crick is identified, and then we'll go together to the exchange and then the letter that was also sent on the 14th of April. In fact, I know that the messages are important. Let's deal with the messages first, and I'll look at the policy. So please,
Sure.
Can we display? So first of all, can we display, please, I&Q 000292606. No, I do apologise. 0093326. I do apologise.
Okay.
That's 000093326. Apologies for the delay, Mr. Hancock, because there have been late additions. We're not as agile as we usually are with the exchanges. So it should be 000093326.
You're getting a message that we don't have it loaded.
Well, let's come up. We'll deal with this
Don't
as a
have it.
topic, Mr. Hancock.
Okay.
We'll deal with it as a topic, as a piece, after the break, when it's been uploaded.
Okay.
Well, then, let's go to the letter from the Crick then.
Okay.
That was, and it's evidence we've heard last week from Sir Paul Nurse, of the letter that was sent to you from himself, please. Will you just allow me a moment? It's I&Q 587060. That's I&Q 000587060. And Mr. Hancock, the full context of this letter will be understood when, after the break, we've gone through the text messages you want to detail.
Yeah. Okay.
Thank you.
But the critical thing to notice, I guess, in terms of timing, is they're both. This is sent on the same day as the advice changed early in the morning.
Understood,
Yeah.
Mr. Hancock, but it's right to say that certainly Sir Paul Nurse have been seeking to make contact to share the work of the Crick from February onwards, but this is the formal letter that identified what they had found. And as you can see, Mr Hancock, the concern in particular with this letter was that what had been said on April the 6th at the House of Commons Select Committee, it details this. We followed the committee's debate on the adequacy or otherwise of testing capacity within the NHS, but were surprised that as far as we could hear, no mention was made in that assessment of the need to test asymptomatic or oligosymptomatic individuals, be they healthcare workers or patients. This is of great concern in view of emerging evidence that a high proportion of infections are asymptomatic, obviously entraining a high risk of transmission between and among healthcare workers and patients.
Yeah.
And then we can see it goes on to say, we assume this has already been debated amongst Her Majesty's at that time government advisors, and you might feel that appropriate responses have already been considered. However, there are several reasons for our concern and for writing directly to you in this way.
Yeah.
These are as follows, and you can see our perception is that at present there is reticence about doing more widespread testing of healthcare workers. It will clearly be expensive and yet another challenge for hospitals that are already under pressure. Some have privately expressed their concern that making a positive diagnosis in asymptomatic healthcare workers who might otherwise continue to work will deplete staffing levels at a time of need. Whilst perhaps understandable, these concerns are not productive in terms of the overall goal of controlling the epidemic. Rather, it will result in recurrent problems of seeding fresh outbreaks with staff absences and the potential for infecting non-COVID patients in the healthcare environment. Importantly, we consider that these concerns can only be overcome by a clear central directive from you as Minister. And then you can see it goes on to identify the operational issue and repeated testing for healthcare workers. We are concerned that this may not have been fully appreciated. To avoid delays, it is essential that this is done in parallel with the development of testing capacity itself. And again, we can see the most accurate interpretation of testing results is only likely to be achieved by systemic repeat testing in vulnerable groups. Such data collections will be essential for accurate assessment of whether and for how long a particular titrate of antibody against a partial viral antigen is indicative of protective immunity. And then over the page, please. You can see the conclusion, and in particular, our concern is that if this is not done, the current initiative to expand testing itself will not achieve the desired effect, and the breathing space potentially achieved for the NHS by the lockdown will not have been used effectively. And so can I ask you, did you receive this letter from Sir Peter Ratcliffe, Dr. Sam Barrell and Sir Paul Nurse?
I don't recall seeing it at the time, but in a way, I'm not surprised. It would have gone to my correspondence unit, and they would have read it, and I agree with all of it, and we were already acting on these points. And you can tell that by the fact that we were that very day, the day this was written, we were already acting on the, as he puts it, the emerging evidence of asymptomatic testing. And you've got to recall, the timing is absolutely critical here, that the CDC had come out with the first concrete evidence just under 2 weeks before, on the 2nd of April. I've since this was...
Mr. Hancock, can I just pick you up on that? So you've just identified that the CDC had picked up on the first concrete evidence of the 2nd of April.
Published on the first about the first concrete evidence.
And so with that answer, can you help them why that had not resulted in action before the 14th of April?
Well, we had the moment that the CDC publication came out, we took immediate action to consider the impact of that on all the policy that we had, and the publication with respect to asymptomatic testing and care homes. As you can see, the formal advice was changed to me following Chris Whitty's evidence review on the 14th of April, so 12 days later. This letter, I understand, I was a bit surprised to see the reference to it on Friday, because I knew that Paul Nurse was talking to Lord Bethell, who was my junior minister on this area and was absolutely brilliant throughout this period. And I've since discovered that the day after this letter was sent, Paul Nurse and James Bethell had a discussion about it. So the letter was clearly acted upon within the department, despite the fact that, as you can see from the other paperwork, all of the points in it were already under consideration at that time. So essentially, my reading of it is that the team at the Crick, the eminent scientists, had come to essentially the same conclusion in essentially the same period of time as Chris Whitty had, and we were acting upon those, upon the new evidence and the insights in the letter already, and therefore the team in the department must have decided not to put the letter up to me because it didn't contain any new information.
And you've identified that these are eminent scientists. Both Sir Peter Ratcliffe and Sir Paul Nurse are Nobel laureates. Was that known and appreciated by you in April of 2020?
Well, of course it was, but it was also irrelevant. What mattered, given how unbelievably pressured everybody in the system was is there new information, and how credible is that new scientific information? And from what I've read of the paperwork, that which I was aware of at the time and that which I was not aware of at the time, it wasn't my decision not to see the letter, obviously, but it was the correct decision not to show it to me because it didn't bring any further insight over and above that which Chris Whitty and Patrick Vallance had already brought to me in doing, as Chris put it, the evidence review and therefore changing policy. So what happened, my summary of the timeline here is that evidence accumulated of asymptomatic transmission. The CDC publication on the 2nd of April was critical. As it happened on the same day, the WHO reiterated its position that there was no asymptomatic transmission. So you've got to think about the global context here. We acted immediately upon that new evidence. Chris Whitty did an evidence review, and 12 days later, he came forward with his evidence review. It took into account the points made by these and many other, no doubt, eminent scientists. And on the 15th of April, so the day after the evidence review was concluded, we changed the policy. I think, having considered this and looked back on it, would it have been better, with hindsight, to have assumed asymptomatic transmission from January? Yes, because there was asymptomatic transmission. Were we on that issue all the time, considering all the evidence? Yes, we were considering it. We were debating the exact nuance of how to describe it. And as soon as the concrete evidence came through, we then changed policy within 12 days. That's what happened.
Mr. Hancock, you characterised that it was the right decision for this correspondence not to be placed before you.
Yes.
But particularly Sir Peter Ratcliffe is one of the preeminent experts in this area.
Yes.
And set against a background of you having had conflicting or differing advice on a key and important issue of policy, at the very least, should this letter have not potentially supported you reaching out to these eminent Nobel laureate experts to seek their input or views to assist you in decisions of policy and strategy?
I guess the answer to that question explains why the contextual piece at the start of this discussion was important. Because on the 14th of April, I'm driving the vaccine push. We're in the middle of the work to reach 100,000 tests. We are we're 3 weeks into lockdown, so the number of cases will just have been turning. We were working on the expanding the Nightingale project to ensure that there was bed capacity, which was used, by the way, an often forgotten fact. So these people are wonderfully eminent scientists, and their scientific evidence was taken into account by my scientific advisors, who had, by the time the letter was completed, had already taken the evidence contained with it into account and put it into government policy, which we published the next day. So I could have spent my whole pandemic corresponding with former Nobel laureates. They're amazing people. They've done incredible work. But to complain about the actions of the correspondence unit when they got a call from the minister the very next day, I think is a bit much.
Well, can we then look at the response that followed on the 6th of July, please? INQ 587061. Obviously, it's a letter that was not sent back by you, so INQ 587061. So the 6th of July 2020, this is the response that was received by Sir Ratcliffe, Sir Nurse and Dr Barrell. Can you assist us to, firstly, why it took till the July for the response to what were clearly concerning issues for the CRIC to be responded to?
Well, obviously you're not calling the departmental correspondence unit, but in their defence, and I feel quite strongly about this, in their defence, we were unbelievably busy. There was a global pandemic, and the amount of correspondence that the department received increased enormously. And critically, most of the jobs that most of the people in the department were doing at this point directly affected how many people died. How quickly we replied to 2 eminent scientists and their team on matters that had already been taken into account, were already in the scientific advice, were already in the government policy, was not going to save anybody's life. I apologise profusely if they are upset by how this happened, but I think, personally, I think that getting a phone call from the junior minister and having continued engagement with the team over that time, that's what matters.
And Mr Hancock, just to complete the issue, and then I'll take you to the document that references the CRIC. Are you able to help as to why this correspondence responding didn't address at all the issue that they had been raising and flagging around the issue of asymptomatic transmission?
No, I've not seen this letter before today, but all I can reiterate, and I'm sorry to bore on about this, is that in the department, what we were doing was everything we possibly could to save lives. If something didn't have an impact on saving lives, it wasn't a priority. And of course, there were many bruised egos in this whole process, but my total focus was on saving lives. And the team would have known that. And that's the answer. We got the information that we needed. There was engagement with the appropriate person. And no doubt there was engagement with the scientific team with Chris Whitty. I know for a fact, because I've seen it, there was engagement with the junior minister. This inquiry should be about how we respond next time, not how the correspondence unit acted during the
Can I just interrupt, Mr Hancock? You said that bruised egos. With respect, the evidence of Sir Paul Nurse wasn't about his ego or that of Sir James Ratcliffe. It was about their expertise and their skill that they're offering. Now, I understand the arguments you made. I just wanted to correct the bruised egos point. That wasn't the point that was being made.
Well, in that case, how it was put was very unusual, because what matters is if they had valuable additional evidence that it was brought to bear, right? And they were engaging with my scientific team, they were engaging with my ministerial team, the information was already being taken into account, it was already being put into government policy. You know, we had endless people writing to us saying, we have this insight, we have that insight. What mattered was the quality of the insight, not the number of letters after people's names.
Mr Hancock, this is not an issue about a correspondence. This is about expertise in London that had identified that asymptomatic healthcare workers did have COVID. They had identified it on the tests that they were running, and they had sought from February onwards to communicate that, and then latterly with this direct letter to you with a desire to influence and change policy and strategy. So it's not about correspondence or egos.
But, you say that, but this letter, the incoming letter on the 14th of April, was written after the contents of the letter had been inculcated into government policy. So I just don't know why we're getting so caught up on it. If you have evidence that the CRIC had concrete evidence of asymptomatic transmission in February that I don't know about, then I wish I'd known about that at the time, but it wasn't brought to me. I haven't seen any of that evidence, and I think that's because there wasn't evidence, right? And so the point of hindsight is to tease out what matters and what doesn't for the future, for lessons for the future. There was, of course, anecdotal, unproven evidence of asymptomatic transmission. I knew about that in January, not February. The official advice and the global position on this remained that there is no proven asymptomatic transmission. It would be perfectly reasonable to conclude from this that in future we should assume asymptomatic transmission, whether or not we have evidence for it. That's worth having. The argument that is implied by this whole last 15 minutes is that somehow somebody eminent who'd won a Nobel Prize knew something and we ignored it. That's just not true. It's not what happened.
Well, Mr. Hancock, then with a view to building on views that might assist recommendations, let's just briefly look, please, at the guidance that was issued by the department, please. INQ 566086, please, which is a guidance from the Department of Health and Social Care of the 8th of April. Thank you. So this is obviously a guidance document, but within the document, if we could just move forward, please, to page 11, one of the annexes to the document was detail in setting out the work of the Crick Institute. And so one of the first things I just want to touch upon then, was there then a lost opportunity for proper engagement and liaison with the department to then harvest the important research and outcomes that the Crick had identified, and particularly where the department itself was relying upon the Francis Crick as the work that they were doing?
No, unless you've got evidence of that, I don't think it's possible to conclude that.
Now then, can we use this then to build on, I think, something that you do have a view about? Because the inquiry's heard evidence from a number of professors, including Sir Paul Nurse, that there was a missed opportunity here to, as part of the scaling up, to utilise the laboratory network that existed for places like the Crick. We've heard evidence from Professor McNally about the ability and availability that existed in university laboratories. And with a view to address this evidence through the prism of recommendations, can we seek your views as to that utilisation in a future pandemic of the wider network of laboratories that exist that could do the PCR testing, please?
So I think this is a really, really important question. And if this module of the inquiry concludes any one thing, the single most important thing is to conclude that the industrial scale expansion of testing is necessary and we need to be ready to do it. And I put this point very, very emphatically because there are entirely understandably people who say that the disaggregated scientific, PHE and NHS facilities should have and should in future be used to scale up to deliver the testing programme. The challenge, as per our discussion right at the start of this session, is that the degree of scale-up needed is of a wholly different order to what is possible.
I'm going to stop you there, Mr. Hancock. Sorry, because you've made that point before, but the point that Sir Paul Nurse was making was different. It's not that you don't need the industrial
the big one
scale.
as well.
What he was saying was, did we sufficiently utilise the existing local network whilst we built? So that's the point.
Okay, that's totally reasonable. And the answer is we continued to use the disaggregated local area. It was pillar 2 of this testing programme. They continued to scale up slowly in the same way that they'd scale up slowly from mid-January when the test became available to mid-March when I took responsibility and we started building the mass testing. So the answer, he's absolutely right that we should continue to use it, but nobody should argue, or we certainly, in my view, shouldn't recommend that should be the main focus. That it's just not possible. Some people have said we should have put more into that area. I would have liked to put more into every area, but the area that was delivering the scale up at the speed that was needed was the industrialisation pillars, essentially. I think pillar 4, because pillar 3 was the antibody testing. That is what is necessary. And it's totally understandable. I understand how if your testing unit is expanding a bit and making a contribution, then you feel like you should do that even more. Well, yes, but if there's a great big factory over here that can radically increase capacity, that's understandably and correctly where the focus was.
Mr. Hancock, then can I explore with you whether there was thought given to what was possible and capable in the existing laboratory network? Sir Paul Nurse has indicated that it would have been, they would have had an ability, improving on the sort of 4,000 tests that they got to get pretty quickly to 10,000 tests.
Well, great, but we needed 300,000 tests.
Well, let's look at this through the target that you set at the end of April to get to 100,000 tests.
Yeah.
And so in terms of the speed to get there, if that was the target, the examples given is you only need 10 such laboratories at that time to get to your figure. And on top of that, we've heard evidence that the university network, so the 40 or so universities that have laboratories with the connectivity to the local hospitals and for the data to go across, they also were preparing and ready to scale up to provide thousands of tests also. But that was brought to an end when essentially their PCR equipment was collected following the email of the 19th of March from Jeremy Farrar. So at any point when you were seeking to achieve the 100,000 as quickly as possible that was needed urgently, did you give a thought to the alternative which was being offered by individuals such as the CRIC and the university network?
Of course we did. That's what we'd relied on for 2 months before the middle of March. And even on the figures that you've just given, if a lab doing 3,000 had managed to get to 10,000, that is a 2.5 times increase, and it's laudable and it's great. But we didn't need a 2.5 times increase. I'd asked for a 10 times increase over 1 month, and we then went to 200,000 the next month. So it's absolutely reasonable, laudable, and great that they continued working in that direction, and they did, and they continued what I would describe as a linear expansion of the capability. What we needed was an exponential expansion of the capability, and when we moved to an industrial scale system, that's what we got. And it's no surprise that the people involved in doing the disaggregated approach support the disaggregated approach. Of course they do, and they threw themselves at it, and we should all be very grateful for that effort. It made a contribution. It was just that we got a far bigger contribution in the systematized, industrialized process. And just think about it in sort of basic process engineering, right? Universities are not designed for Henry Ford style throughput. And that's what we needed, and that's what we built.
Yeah, and then finally, before the break and after the break, Mr. Hancock, I give you assurance we'll go through the messages of the 14th of April. But again, on the decision that's made then to move to the industrial scale and the first 4 lighthouse laboratories that then came online in April, necessarily creating this vision was not going to happen overnight. They had to be equipped, resourced with both the skills and expertise. And was any thought given that rather than simply taking the equipment from places where they could continue to provide tests into the system, that a better option would have been to time when the equipment moved, because essentially there was no then test, because you removed the test from where there was the expertise and the skills when the machines were taken to be placed in the lighthouse laboratories.
No, we didn't. We didn't not have tests then. We increased the number of tests. So it's a totally reasonable line of questioning, so long as we don't think that it's the only answer, or a valid critique of the system as a whole that was built. Of course, there's an impact. If a university lab is doing a few hundred tests on a PCR machine, and you essentially requisition the PCR machine and you put it into a factory setting, then of course that university can't do the tests. I understand that, and we took the people with them in some cases. But the machine is there in the factory setting doing more tests.
But that's the issue, Mr. Hancock. It wasn't. No, there was a time before it then scaled up.
That's simply not reflected in the figures. The figures are that the number of tests increased during this period. It is absolutely true that it increased slowly during April as we built the system, and then exponentially towards the end of April. But please, if this inquiry concludes that what we need is next time round is to use the disaggregated system, because the voices who advocate it are eminent scientists, there is a totally different capacity between scientific inquiry and industrial scale testing. And if we make the wrong conclusion for the nation on this, then whoever's in my shoes next time round will take exactly the same decision that I did, but instead of preparing for the mass scale up, there will not have been the preparation done.
I have that,
and that would be a
point well
mistake.
in mind,
Thank
Mr.
you.
Hancock.
Thank
My
you.
ladies, at a convenient moment.
It is. I shall
Thank you.
return at 25 to.
Thank you.
Ms Cartwright.
Thank you. Now, Mr Hancock, we've got the exchanges relating to the 14th of April now ready to go, and with great gratitude to the relativity operator in the room. Can we start then, please, by displaying INQ 00093326, please? Thank you. And can we go to page 3 within this document, please? And if we can look at the entry timed at 8:16. Thank you. We can see there, Mr Hancock, you're the owner of the cell phone, is that correct?
That's right, yeah.
Thank you. We've got Chris Whitty has done an evidence review and now recommend testing of all going into care homes and segregation whilst awaiting result. This is obviously a good positive step and we must put into the document. And so is this the new information that's been being brought to you on the 14th of April that you've been telling us about?
Yes, and I'm sorry that in my evidence before the break I was a bit emphatic, but in a way this message sort of encompasses that, which is that we'd had this enormous frustration over the evidence and the formal evidence, and finally, after all of that, which I sort of slightly relived in the previous session unintentionally, finally, on the 14th of April, I get the formal evidence review from Chris Whitty that recommends testing of all going into care homes. And this is something that I had wanted, worried about from the start, but not had formally advised to me. And so the sort of, you can see it here, that there's a sort of sense of release and relief that finally what we had been, all of us had worries about, and I was now formally acknowledged and we could get on.
Thank you. And obviously we can see the questions asked. This includes all those asymptomatic to right, and if we just go one below, we get your answer yes.
Yeah, and Alan saying, just checking, this includes all asymptomatic. So he is sort of, there's an element of surprise in that this is all asymptomatic cases, because of course until then tests have been regarded as not reliable on asymptomatic test cases.
I'm going to move across documents just to capture the timeline. Can we next please display 292604, please? That's 292604. So that was 8:16. We can then see at 9:19 an email from Alan, and that's the same Alan in the messages, is that correct?
Correct, yeah.
Where we can see, hi all, Secretary of State has just texted to say Chris Whitty has done an evidence review and now recommend testing of all going into care homes and segregation whilst awaiting result. This is obviously a good, positive step and we must put into the doc. Please can we action this ASAP? So we're just going to follow these through. I don't think that needs any extra commentary, Mr Hancock, unless there's anything else you'd wish to say about that document.
No.
Thank you. Can we then go to 292606? So we move now from 9:19, and at 292606, we're now at 12:14. And that's, thank you. We can see an email from Ros. Can you just identify Ros's role, please?
Yes, Ros Rawton was head of social care policy at the department.
Thank you. And we can see she details in this email, dear all, in light of the prevalence transmission of COVID in care homes, the Chief Medical Officer has asked us to move to a policy of testing all individuals before admission to a care home, testing all symptomatic residents in a care home. This will be announced tomorrow as part of the Social Care Action Plan publication. Hitherto, local Public Health England health protection teams have been undertaking some measure of testing in care homes, but it is clear that there is insufficient capacity to do this at the scale now asked, and we will need to develop a different operational model to deliver this new ask. I don't know realistically what that is, but I'm copying you all as people who might be able to help generate ideas and help us access, e.g. Community Health, Care Quality Commission, the testing community. And then we can see, I think a little further down, please can you set up a meeting this afternoon if possible, people on the copy list or people they recommend, and we can see the suggested agenda, scope of new testing ask.
That's right.
Thank you. So then can we move then from this email timed at 12:14 to INQ 292606, which is a readout of that meeting, which is at 13:44. So INQ 292606. Thank you. Sorry, I do apologise. I've been a rogue record. 292605. I do apologise. 292605. Sorry, this is the readout of the meeting at 1:44. And if we just go down, thank you, we can see Ros updated that we've agreed with NHSE and local government wording on discharges in light of CMO testing wording. A lot of work to operationalise, looking at getting nursing staff to take swabs in care homes. Secretary of State said we need to ensure the nurses are in PPE or have been tested. MSC noted the wording on whether testing is on admission or discharge is a bit confusing. And then again, action team to clarify wording on testing. Again, is there anything extra commentary you wish to give in respect to this email, or is it simply to ensure we've captured the chronology?
No, it makes sense. The key point of this is that the new CMO advice came in that morning. By lunchtime, we were turning that clinical advice, operationalising that clinical advice, taking into account the constraints that Ros put in her previous email, the availability of testing, for instance, and all in the context of them publishing the government policy the next day.
Thank you. Then can we move, please, to INQ 93326? So we are now at 5:23 on the 14th of April. That's INQ 93326. And I think in this exchange, it's the update around what had happened in the meeting and the change to the decision on testing. Ms Hancock, is there anything else in respect to this exchange you wish to highlight?
No, so this is just merely a distinction between the advice was to test those going from hospitals into care homes, and there was a debate about whether to also say that in the future we would test those going from the community into care homes, and we decided only to say the former until we were confident that we could do the latter, but it didn't make a policy change. It was merely about whether we would forward indicate the testing of those from the community.
Thank you. Can we then move to INQ 292608, please? That's INQ 292608. Thank you. And we can see that this email is 6:49 in the evening. If we can scroll down, please. This is another email from Ros Roughton, where, again, we can see she identifies, dear all, I've just talked to Erdin, Secretary of State's office about this, informed by a meeting with PHE, CQC, NHSE and others from Testing World on how we operationalise this. We agreed we can press ahead straight away with hospitals testing patients who are going to care homes, and then we can see the aspiration. We think the numbers on this are under 8,000 a month. It's really important that we keep this aspiration in, as we need to build care home confidence that we are doing our best to help them keep their residents safe, and this will be an important part of it. This was also the advice earlier today via the Chief Medical Officer.
Right.
Thank you. Then if we move, please, to the next part of the chronology, INQ 292609. Thank you. We're now at 8:12 in the evening. And we can see, essentially, again, a recording that we agreed that on expanding of testing to all residents of a care home where an outbreak is suspected confirmed, the next step by closed tomorrow are. And then we can see, again, that through. And again, we agreed that on the policy to test all hospital patients ahead of discharge to a care home, discharges are estimated to be 500 per week.
Yeah.
And so, Mr Hancock, is there any other context we need to consider on this email as part of the chain that went to the policy change on the 14th of April?
No, I guess what it shows is simply the speed of action from the policy change, the advice change first thing in the morning, through to here we are at 8 o'clock at night with the team putting together the details of how this can then go into action.
Thank you. And finally, then, just to complete the point of the chronology, 292611, please. Thank you. So we're now the following day at 7 minutes past 10 in the morning. Again, Ros to the various recipients, but again, we can see, hi Natasha, And then the detail, essentially detailing that they want us to restrict the testing of patients in hospitals going to care. So let's just identify NHS England Simon.
That'll be Simon Stevens.
Thank you. You say they want us to restrict the testing of patients in hospitals going to care homes only to those patients who are going to care homes for the first time, not those who are returning to their care homes. They are concerned about their operational capacity to do that, as they're trying to establish how many people are admitted from a care home. I think in policy terms we should be committing to testing everyone going to a care home from hospital.
And that's what we
thoughts on
did.
handling? Yeah. Thank you. And so, Mr Hancock, I said we'd go through the wider exchange that you were anxious that was properly considered when you had that change of advice from Mr Whitty.
Yeah.
Is there anything else before we move to the last number of topics that I wish to consider with you?
No, I think that takes us through the
Thank you.
chronology of that.
Thank you. And then can I ask again on asymptomatic workers and testing?
Yeah.
One of the issues that's been explored with a number of witnesses in this inquiry is then the fact that Wales then implemented the policy a later time to England, a couple of weeks later, but also there'd been some reference or suggestion that there was no value in asymptomatic testing. Can I ask you, having gone on the journey you've told us about, particularly through March and April, do you have any views about, at a later time, sort of 2 weeks on, a position being adopted in a different devolved nation that was still saying there's no value in this?
Well, I do remember the First Minister of Wales saying that you shouldn't test people who are asymptomatic a bit later, and I remember thinking we need to make sure that he gets the updated advice that I've seen, but I can't remember being any more involved than that.
Thank you. Now, Mr Hancock, I'm going to deal with Lord Bethell because he was essentially tasked with the scaling up from the 17th of March when the decision was made to move towards the mass testing approach. So please know that that chronology will be dealt with Lord Bethell.
Yeah.
But can I ask you then, just if you can do it in a compact way, we know that PHE was essentially disbanded and it moved then into essentially what became NHS Test and Trace and then UKHSA.
Yes.
But is there anything else particularly that this inquiry should consider as to that decision for you to disband Public Health England?
To disband them overall?
Yes.
Well, the reason that was a decision taken in August of 2020. The reason to do it was to ensure that there was really about preparedness. It was making sure that there was a body whose only worry was to prevent communicable diseases and to keep up the fight even when there wasn't a pandemic on the horizon, like now, and a group of people whose job and where the leadership of the organisation had a job to wake up every day worrying about the next pandemic. There was a debate about whether we should do that in August 2020, given that the pandemic was still ongoing. There's a perfectly reasonable argument that we should have waited, but it was clear to me that we needed to take the action, and we also needed to find a permanent home for NHS Test and Trace.
Thank you. Mr Hancock, there's a number of topics I just need to deal with, so they don't follow a particular order, but so please just bear with me in terms of these topics. Now, the inquiry of her has some evidence that we're going to hear later, so I want to give you an opportunity. We're going to hear from Professor Pillay on the last day of the inquiry. And essentially, he has summarised that you conflated tests available with tests undertaken. Can I ask, regardless of your intention, do you accept that this inevitably risks creating public confusion, particularly when you were making daily statements that gave the impression those tests were actively being used to protect lives?
No, we published both the availability of tests and the total number of tests done. So we went out of our way to try to ensure clarity on that, and we put quite a lot of effort into precisely designing how that was published to try to minimise anybody conflating the two.
Thank you. And again, the source of this question is also from Professor Pillay's statement, which I know was provided with the pack.
Yeah.
He also notes that both virus tests and antibody tests were counted towards the target, despite antibody tests providing no useful information at that time. are you able to assist as to why tests with no diagnostic value were included in a figure being presented as a measure of pandemic control?
Well, it's not quite right to say that antibody tests did not matter at that time, because it was absolutely critical to have enough antibody tests to do the survey that later both Lord Aradazai and the ONS put together to understand how many people had the antibodies, because at that point we didn't know how much of the population had been exposed to COVID and whether enough had been exposed that we wouldn't need a vaccine to get out of the pandemic. And it turned out that not enough, there wasn't enough exposure. So antibody tests were important. Of course, they were different, but we needed a metric. And the point about the 100,000 target is, in a way, incredibly simple and obvious, which is it was there to galvanize the system to grow radically. And we slotted all the different testing pillars, as we called them, into it, because we wanted to measure the overall growth of the system. And people have said, well, that was done at the expense of what we should have used the tests on, or the exact type. The point of the target was precisely to be simple and bold, so everybody knew what we were going after, and it achieved that result. And by growing testing, we removed a whole load of the other problems that came from not having enough tests.
Thank you. Now, my next topic of questions, please, Mr. Hancock, is the award of contracts to Randox. You detail the full context, so again, please know that will be uploaded today. Now, if we could please have displayed your paragraph 129, please, within the witness statement, just so you have it in front of you as I summarise that. So paragraph 129 of INQ 587294, please. I think it's page 40, INQ 587294. Thank you. Now, you detail and defend the awarding of substantial contracts to Randox by emphasising their role in stepping up during the national effort.
Yeah.
But you'll be aware that the National Audit Office recorded that a 328.3 million contract variation was awarded to Randox in October 2020 without competition, more than double the original contract's value. Do you accept, Mr. Hancock, that at the very least, to maintain public confidence, a contract of that scale should have been handled with maximum transparency as part of the creation of the test, trace, isolate system, please?
In a utopia, yes, but we weren't living in a utopia. People were dying every day, and Randox had the capacity to radically increase the number of tests available, along with the other testing companies. And the idea that these contracts should have been competed implies that we might not have taken them because we were choosing between companies, which would be normal in normal times, but these weren't normal times. So we needed to buy in all of the testing capacity that was possible and testing capacity that hadn't yet been built. And that's why we took the approach that we did. It's a context question again, because the context was that tests were necessary to keep people alive, and we didn't have enough tests as a nation, and so we were buying them from wherever we could get them.
Thank you. Now,
I mean, look, Randox, I just want to put on the record my thanks to Randox, who did an amazing job during this period, and they, as I put here, they stepped up, but they really lent into this problem and tried to grow, as did other testing companies.
thank you. And Mr. Hancock, I'm sure you appreciate that these questions are asked in a context of a pandemic, but also the importance of transparency and by reference to the involvement of Mr. Patterson.
Yeah.
But can I ask you then, please, there were plainly ministerial meetings that were not recorded that have also been commented about. Were you at the time aware that those meetings had not been properly recorded by reference to this?
No, not that I can recall.
Thank you. Could I next please to be displayed your paragraph 258? And Mr. Hancock, this is the last topic before I'll finally give you an opportunity to say anything else around recommendations. So paragraph 258, please. Thank you. Thank you so much. Now, we can see, this is in the context, please, of just some assistance on the support payments.
Oh, yeah.
You detail there's agreement at COVID to ramp up communications, provided grading funds for discretionary support payments, increasing non-financial support, but not despite your arguments for making universal support payments. Now, we know that the 500 figure was available in October 2020. And the question, please, under this theme, can I ask you, you agreed to introduce the £500 support payment for some groups. Do you accept that under that scheme, many working people were ineligible, yet still unable to afford to isolate?
Yes, you said I agreed. I wanted these to be much more generous.
Thank you. And
So, of course, I accepted some movement in the right direction, but I didn't think it was adequate.
no, thank you. And I think there's more detail about that in liaison with the Treasury in your statement. Then can I ask additionally, given the strong evidence that financial reasons were essentially causing people not to adhere to self-isolation requirements, and particularly when it became enforceable, do you believe that the Treasury was placing politics over public health?
That is not how I'd phrase it, no. They had a concern that if you introduced a scheme of universal payments, it may be gamed or it may be hard to withdraw afterwards. But their concerns, I thought, were they were valid balancing arguments. They were made for the right reasons, but they were, in my view, outweighed by the arguments in favour. It comes down to the doctrine again. Spending public money to pay people to isolate in order to stop the spread of the virus is not only obviously good for health, it's actually good for the economy because you have to have fewer other NPIs. So my view is that this would have been good value for money as well as the right thing to do from a health point of view. Treasury made the argument that concerned more about the direct payments. I respect their arguments, and they were made in a respectable way, and I lost that argument inside government. But one of my recommendations would be to have generous universal payments for required self-isolation.
Thank you, Mr. Hancock. And then finally, plainly, you've woven through your evidence a number of recommendations, but can we move, please, to paragraph 274 of the statement at page 96? That's 274, at page 96. Thank you. You detail, by way of lessons learned and reflections, that the key lesson for the future is that a rapidly scalable testing and tracing infrastructure should be maintained, ready for urgent expansion. You say this, I'm concerned that at present our current capacity is being dismantled and we will find it much harder to scale again in the future as a result. It is a vital weapon in the government's armoury to combat any new disease, and depending on the transmissibility and virulence of that disease may be sufficient alone to suppress and contain it without having to resort to further social distancing measures. In my view, that justifies the cost of building and maintaining testing systems that are rapidly scalable in the event of new variants or an entirely new pandemic.
Yes.
And so, Mr. Hancock, can I ask you, in terms of what we now know that the whole Lighthouse laboratory infrastructure has now been dismantled, have you any views on that, it being part of the infrastructure that you created in the pandemic?
Yes. I think about it practically. You can't have... it's hard to make the case for a permanent, large factory settings sat empty, waiting for the next pandemic. That would be, in a perfect world, what you'd have, in the same way that you have a standing army. There is a case for it. What there is, in my but there's also a case against because it's expensive. What, in my view, is there is absolutely no case against is having a plan and a system ready to go to build those factories, to take the units, to bring in the PCR testing machines or whatever the latest technology is, and to be ready to go. And to the point you asked about earlier, having the data structures ready with the integrations so that this can all be stood up. Now, taking the army comparison one stage further, we do have a standing army, even though there have been times when we haven't been physically under threat. Considering we spend a drop in the ocean on biological defence compared to physical defence, there is actually a good argument to have these this system actually maintained. But I can see the case against. What I can't see a case against is having the rapidly scalable testing and tracing infrastructure, and then I reinforce the point I made earlier that of course the disaggregated element of this is a contribution, but on its own it will not be enough in the case of a pandemic that is as virulent and transmissible as last time.
Thank you. Mr Hancock, those are my questions. My lady, there are core participants' questions.
Thank you. Mr Jacobs, who's right over there, Mr Hancock.
My lady, questions on behalf of the Trade Union Congress were regarding financial support for self-isolation. In fact, given the questions just a few moments ago and the clear answers given, I don't think I need to take your time.
I did wonder. Thank you very much for helpful position, Mr Jacobs. Mr Thomas, who's over there as well.
Good afternoon. Very good to see you again.
Thank you. Ms Hancock, I've got a few questions for you. As you know, I represent FEMHO, the Federation of Ethnic Minority Healthcare Organisations. FEMHO members have reported concerns that in the early stages of the pandemic, there was a lack of tests available, A, for those working in healthcare settings outside of hot zones, such as porters, cleaners, all of whom have since been shown to have had high rates of exposure and transmission. And secondly, for households of healthcare workers, despite the risk of transmission at home. So my questions are, firstly, were these issues considered when decisions were made as to the prioritisation and rules on who was and who was not eligible for testing in the early stages?
Yes.
Can you explain how those decisions were made?
Ultimately, I relied on clinical advice on the prioritisation of availability of tests. The question I asked the advisory team was, how do we prioritise these tests in order to keep as many people alive as possible? And I don't recall deviating from the clinical advice that I was given in making the decisions on testing prioritisation. What I would say for the future is that it's vital to understand what happened and the disproportionate number of deaths amongst people from ethnic minority backgrounds and in the public-facing and patient-facing roles, especially within the NHS, and ensure that that learning informs a clinical prioritisation next time.
Okay. Well, I think you've just answered my second question, which is looking forward, what would you would do different, and you've answered that. So let me move on to my third question. How was data and modelling used to inform the TTI policies and operational decisions during your tenure, particularly in relation to identifying areas or communities at heightened risk?
Well, it improved during the whole period, I think, is the best summary. We started with very little information, as you know, And the early information was about proven cases and hospitalizations and deaths, because sadly they are the most measurable things in a pandemic before we had better testing available. Once we had the various surveys up and running, the ONS survey, the REACT survey, looking at the work of Professor Tim Spector, that gave us better information to be able to make decisions which were more led by the data. Unfortunately, I remember very clearly the early data coming through with a very strong and clear disparities in terms of negative impact of those who were in the frontline medical positions. And I say positions because it was whether clinical or non-clinical. It was about how many interactions you had with patients ultimately. But the data started off very poor and it got better.
Can I ask you this? Was disaggregated data by ethnicity, socioeconomic status, or geography used as a guide to guide resource allocation or the targeting of support?
Yes, it was. And I would say that we got better at that. And there's a lot of lessons from what happened that can and should be learned that should then go into best practice right from the start. We touched on this, I guess, with the interaction of a national and a local testing system, because local capacity, both in contact tracing and in testing, can be better at responding to and reflecting the community that it's close to. National systems inevitably find that harder because they tend to be more one size fits all, and that's why an interaction of the two is probably best.
Okay. Were there gaps or any limitations in data collected that impeded understanding of the pandemic's impact on minority ethnic communities?
Well, there absolutely were at first, because there was a lack of testing. And I guess the question that you ask and the implication in it reinforces the point about the importance of antibody testing as part of our suite of tests, because knowing who has antibodies as a result of being proximate, being infected, is a really important data point to understand who is being affected over and above the hospitalizations and the deaths data.
Okay. To what extent did the Department of Health and Social Care seek to involve community-led organisations or frontline healthcare providers in interpreting data trends, particularly those affecting minority groups?
Again, I think the answer is increasingly. So by the autumn of 2020, and certainly during the vaccination programme, this was a major focus. And we had the data to be able to target the areas that needed extra support. And the data integrations, as we've heard earlier, to ensure that local teams could see the national data as it affected their area. We had to build that over time, and it wasn't available at the start.
Were concerns raised by some of these organisations about data blind spots or misinterpretations formally incorporated into the TTI policy responses?
Yes, they were. We were concerned about data blind spots, about differing information coming from local and national systems, and not just blind spots, but hot spots as well, areas where there was a huge amount of activity, and that was something that we'd go through in the weekly gold meetings once they were set up to as the high-level management of the TTI system from around September 2020.
Were, and if so what, specific strategies were developed to engage and build trust within communities who historically experienced health inequalities or systemic mistrust of government?
Well, again, we built this and got better at it over time. In a way, from my experience and really reflecting on it, the early contribution that I could make to this was simply to acknowledge it. I mean, that was the starting point. I remember the early press conferences when, the first 4 deaths of clinicians were all from people from ethnic minority backgrounds, and I talked about that in public. So at first we didn't have much data to give a rich picture of, or a detailed picture is maybe a better word, but we could see it with our eyes. And so I tried to talk about it, and then we tried to bring in analysis, some of which was done within government, within the department, within PHE, within the Government Equalities Office. Also, there was excellent work done externally. Ben Goldacre's work, which he published regularly, was very impressive, for instance, at being able to highlight these problems.
A couple more questions. The strategies that I was just touching upon, were there any successful strategies, and how were their impact measured?
So there are a number of successful strategies, and most of them worked, in my view, most of them worked. The ones that were most effective were the ones that looked at the issue from the lens of the community who we were trying to support. So instead of talking about hard-to-reach groups, we tried to think of groups who feel distant from government. They may be suspicious of government more so than the average population, for instance, or concerned when the armed forces were used in a execution of a policy, as one example, which came up quite regularly. I think it's really important that you look at it through the correct lens, look through the telescope the right way, because otherwise you end up in a ivory tower in Whitehall, thinking that people are disconnected, and it's not. And instead, it's important to take responsibility for that disconnect and try to do something about it.
Let me come to my last question. I'm going to roll it up because time's short, and it's that issue of structural racism that I just want to return to in this module. So I'll roll up my question in this way. Can you tell Her Ladyship what consideration was given to the impact of existing structural racism within the NHS and wider health systems when you were designing and implementing the Test, Trace and Isolate programme?
Well, I think the best way to answer this is that we were trying to understand and respond to the likelihood of somebody being infected and being very negatively affected by that. And one of the challenges we had in the data was to disaggregate how much of that was due to socioeconomic factors and how much of that was due to biological factors. And we put quite a lot of effort into trying to work that out. And because if there's a structural problem that is because a virus affects people from a given ethnicity differently, then you need to respond to that. If it's because there are more people in, say, groups that are patient-facing proportionately, then you need to address that. But getting to the root cause of why there is a disparity in impact of the virus by ethnicity, by gender, and by socioeconomic status is important, because you can then only address it if you can understand the root cause of it.
What would you do differently going forward?
Well,
I think that's two broad questions. I'm sorry. We've got a huge amount to get through today. I'm really sorry, and this isn't also a thesis. So I appreciate how important the point is, Ms. Thomas, but I think we're going to have to leave it there.
Thank you, my lady.
That completes the questions we have for you in this module. Mr. Hancock, please don't worry about your passionate responses earlier. I do understand. And I also understand the pressure that you and your colleagues at the DHSC were under. And it's in that context and in that light that any findings I make, I'm not somebody who believes in sitting in a courtroom or a hearing centre in the cold light of day, comes along and says, oh, I could have done it better. That's not my way. So please be reassured.
It's kind of you to say, thank you.
I believe we're going to call on you
Yes.
once more, but I'm hopeful, I'm pretty confident that'll be the final time. So thank you very much for your help this time, and I shall see you again, I hope just the once more.
Thank you very much.
Thank you. Lord Bethell, I'm sorry to keep you waiting, but I've seen you've been following proceedings anyway, so.
My lady, could you please be Lord Bethell be sworn?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and
nothing but the truth.
nothing but the truth.
Lord Bethell, could you give your full name, please?
Yes, James Nicholas Bethell.
Thank you. Lord Bethell, we thank you for the provision of your third witness statement to the inquiry, but the first to Module 7. Could we please turn to page 58 of that statement, please, where we see it's dated the 16th of April of 2025. I can ask you to confirm that the content of that statement is true to the best of your knowledge and belief.
Yes, it is true.
Thank you. Now, Lord Bethell, you've given evidence already to the inquiry twice, and you've already identified, but let's just deal with that now. It's right, isn't it, that you were, during the pandemic, Minister for Technology, Innovation and Life Science, and you are going to help us with the development of that role relevant to test, trace and isolate from the 1st of January 2020.
That's right.
Thank you. And can you just confirm when you ceased to act in that role, please?
September 2021.
Thank you. Now, you have helpfully within your witness statement at the very beginning set out reflections, which I think are quite helpful to deal with at the outset, to give some context to the evidence you wish to give by reference to test, trace and isolate. Could I ask, please, for page 7 and paragraph 4, please, to be displayed? Sorry, paragraph 4 at page 3. I do apologise, I said 7. Paragraph 4 at page 3, thank you. Now, I think you've provided your reflections, including the huge sense of pride at what you were able to achieve from what you've described as a low base. And would it be fair to say, Lord Bethell, that you are going to assist us today with essentially the mass testing that you played a key role in terms of development of, for increasing testing capacity, but also contact tracing also?
Well, I would just add, thank you for that. I would just add that there was also airport testing, which was very, very important. There was also a huge amount of research and surveillance testing. And there was also testing that was done in hospitals. So I think it's broader than just the mass testing.
I appreciate it. And I think you also, within the statement, deal with the red list.
Yeah.
Your statement will be published that gives the full context of your relevant roles relating to test, trace and isolate. But necessarily, we're going to focus on the significant role you played for the increase in mass testing, because I think you've got key and relevant evidence that can assist by way of the chronology of that matter.
I understand.
But then can we have... look at this, you say as the follow, but I also look back with a mixture of frustration and anger that we were put in a position where the public health doctrine, the public health infrastructure and the domestic diagnostic industry meant we started in such a weak position, and that our other policies, particularly the non-pharmaceutical interventions and the welfare support, did not work to support the credible objectives of the test and trace mission as effectively as they could have done. Lord Bethell, do you want to perhaps start with being absolutely clear about your views, having essentially worked practically through the pandemic to scale up in the way that you did?
Well, thank you very much. I think that a lot of the dialogue so far has been about the management of what I would call the mad scramble to stand up testing. And there's been a lot of dialogue about whether that scramble was done correctly or not, and whether we should have used academic testing or other infrastructure in different ways. I think my point here is we shouldn't have had a scramble in the first place. In a 21st century country, there should be a priority on basic public health. Now, we have chosen in this country, quite unusually, to put a huge amount of our resources, about 95% of the £220 billion, into either primary care or acute hospitals. And we put a huge amount into life science research, billions of pounds in terms of research funds. And we put a tiny amount, 2%, into public health. The local public health system, as Matt Hancock made the point of local directors of public health, are tiny. They have minute resources. We have no standing testing facility. Local authorities have a very, very small imprint on their local community. And there is very little dialogue between primary and acute care and the public health system. In other words, the basic foundations of public health are not here in this country, and we will not be able to react to the next pandemic unless the question is asked, why is that the case, and actually an investment is made. In other words, arguments for putting our attention into how to use research laboratories or hospital laboratories better are arguments for the status quo, for not changing the resource prioritization of this country. And in order to avoid this happening again, we actually need to change the status quo and move the resources to supporting basic public health infrastructure in this country. And in terms of the MPIs and the welfare support, which I'd be happy to talk about separately if we run out of time, I do think that a degree of coordination between these things is very important. Specifically, I think a test and trace system can be extremely effective. But if you're late on every single lockdown, and if the prevalence rate nudges up from 0.5%, 1%, 2%, 3%, you're not going to be able to catch up. And you get a pingdemic, as many of us will remember. So I think that coordination point is very important.
Thank you. And can we move to your paragraph 5, please? Because again, with the task that her ladyship has around recommendations, you tell us at paragraph 5 that in the last 3 years, we've gone backwards, not forwards. The diagnostic infrastructure is dismantled. The data spine is closed down. The UK diagnostic industry has reverted to a small-scale, undercapitalised, science-led cottage industry. Our public health infrastructure, particularly the local representation, is weaker than ever. There is little surveillance of domestic or foreign pathogens, and the social habits around home testing and regular health screening have gone backwards. It is therefore imperative that this module lifts its head from any undiscerning interpretation of the headlines and simplistic anecdotage around testing, and instead tackles the more serious issues. And you then set out essentially a framework to consider the issue. But can I ask you then, if we start with this context, because the infrastructure that was dismantled, you played a key role in having set up around the Lighthouse laboratories. And so do you have any particular reflections, having now seen that all of that work and the scaling up no longer exists?
Yes, I'm completely unsentimental about this. A huge amount of money was spent, and to wind down that cost base is very important. And taking tough decisions on that, I think, is a priority, not just for the Treasury, but for the country. But to go back to the old way of doing things has been, I think, a huge mistake. We could have in place a bigger commitment to day-to-day public health screening of day-to-day diseases. That means that we would have infrastructure, maybe in the private sector, maybe in the public sector, that could be suitable for the kind of industrial scaling that we've talked about. In other words, not to just rely on the scientific and pathology labs, but to actually have in place a better basic infrastructure. In terms of the data spine, that didn't work at the time, and we still don't have really good interchange of pathology and tracing in place, and that infrastructure has gone away. The UK diagnostics industry has shrunk to almost nothing and remains extremely weak. And as we know, when the international boundaries are shut, we'll be relying on our own support. In other words, there is no effort to try to learn the lessons and to put in place the kind of warm system that could be fired up when the next pandemic comes along.
Thank you. And Lord Bethell, with your assistance now, I would like to just deal with the chronology of your involvement for the scale-up, please. Can we move to your paragraph 7, please? Because you clarify that it was in fact the 9th of March of 2020 when you were appointed as the Parliamentary Under Secretary of State for Technology, Innovation and Life Science. And you've detailed then all of the portfolio. We can see it goes over the page again. Significantly, obviously, it dealt with testing, trace and technology. We can see at paragraph E, data and technology was included, but plainly your portfolio included much more than just the test, trace and isolate. But it's that I wish to look at with you now.
It is worth just adding that I had been a whip to the department and therefore had been very much embedded in the day-to-day work from, I think, September the previous year.
I think. Well, let's just make sure then the context. You tell us you entered government as a whip in the House of Lords in mid-2019, responsibilities for the Home Office, but then you moved to work as a whip with responsibility for the Department of Health and Social Care. And can you just confirm the date of that? So clear, I think you talk about mid-January 2020. So I want to be clear when you became a whip for the Department of Health and Social Care.
I think it was earlier than that. I think it was in September previously.
Thank you. Now, can we then move, please, to paragraph 10, where you deal with the priorities as the pandemic developed and that were then revised. But I'd like to ask you a question, please, in respect of, as obviously we're going to come to deal with offering mass testing for community in the workplace, but you also include at paragraph 10G, working to increase public confidence in NHS and Her Majesty's at the time government's health policy at a local and national level, measured via robust research, especially targeting hard-to-reach groups. And I think there's a question in terms of that terminology around, if we're looking at it, bear in mind you want to look at the cultural issues and looking at things through the right perspective. Could I ask first, would you agree that it's looking at it through the wrong way to say?
Yeah, 100%. Targeting hard-to-reach groups is unfortunate. I wish that phrase wasn't in there. I thought the way Matt Hancock put it was quite right. And that was a learning that I came up to speed on very, very quickly. Listen, the NHS did not make itself a very easy organisation to interact with for about 20 or 25% of the country. And I was stunned, really, to understand that we have blind spots, communities, ethnic groups, geographies, certain areas of poverty, where really government on the whole, and particularly the health service, has very, very little trust or reach. And therefore, we invested a huge amount in order to create that bridge. And that meant, for different things, literally knocking on doors, working with local community groups, engaging media, and a huge investment in thought, time, resources and expertise went into that.
Thank you. And building on that, Lord Bethell, can I ask, were any impact assessments conducted specifically to evaluate how well the test and trace communications reached and were understood by diverse ethnic minority communities?
Yes, they were. I mean, it had been explained to us in January by Chris Whitty in the most emphatic terms that the people who would be hardest hit by the pandemic were the most vulnerable. That's how pandemic works, full stop. Every single conversation we had about the pandemic started with the assumption and included a discussion of how was it hitting vulnerable groups, including ethnic minorities and the poor. Therefore, we had in place measures on every part of the pandemic, whether it was the vaccine, the testing, the NPIs and so on, and also the impact of the fines. How was this being impacting those who were clearly going to be the hardest hit? And I could go through with you some of the specific measures, if you like.
Thank you. Can I ask you then, by way of the broad topics before we get into the detail, do you agree that financial, physical and mental support were necessary pillars to a successful test, trace and isolate policy?
Yes, we fought hard. In particular, we were conscious that some of the people who were being hardest hit depended on the cash economy in order to sustain their households. And it was very tough for them to isolate without any financial support.
And then can I ask you then, we know when the financial support was available. Would you agree that the test, trace and isolate policy and system did not provide adequate support to people who tested positive for COVID and were required to isolate?
Yes, I would. I would even go further and say there's pretty much no point in doing testing, tracing and isolating if you don't create the circumstances where people can actually isolate.
Thank you. Lord Bethell, I'm going to work from the 17th of March with the change that happened, I think, where the department essentially took the grip and control over the testing from Public Health England. But before we deal with that chronology, can you give us an impression, bearing in mind you'd taken over the responsibility also and a role within Test, Trace and Isolate, of what it was like at that time before you had to move to the mass scaling of testing, please?
Yes, I think that it was astonishing to me that there was no plan or ambition in this area when we arrived. In fact, quite the opposite. The advice was really that such a program was not a thoughtful approach, and we were generally nudged away from the idea that you could have a whole-of-nation, regular, daily testing program. And it took quite a lot to persuade the system that this was something that we should undertake. It was prioritized partly because this was a way to contain the spread of the disease, which has been discussed earlier, was not the original plan at all, but also as a fallback plan for the vaccine, because at that stage, the strong advice was that we shouldn't rely on the vaccine and that we should be thinking about treatments and test and trace as really the alternatives.
Thank you.
Therefore, there was a huge amount needed to be done to galvanize everyone and to enjoin in that vision and that ambition.
Thank you. Can we please display INQ 592582? It's 592582, please. Thank you. Now, we can see this is the 17th of March, and it's significant, isn't it, Lord Bethell? Because
Who's it from? Sorry, I can't see.
It's from Mr.
Oh, yeah.
Hancock. If we go to the bottom of the action.
Or from his private
Thank you.
office, yeah.
Because it's right, isn't it, that there was a number 10 round table on diagnostic testing that happened in the evening of the 17th of March.
Yep.
That was coming up with what is described at point 4, a task allocated to you for Lord Bethell and Professor Farrer, Kristen MacLeod, to come up with a plan for the fastest way to scale up antigen testing using entirely non-NHS PHE facilities, starting with Thermo Fisher possible capacity.
Yes, this memo isn't so clear about the role of the NHS, which was very important indeed. Steve Powers was leading that at that point. Yeah.
Thank you. Now, can we move then to look at the a document that arises from the round table, please? It's INQ 119570. And this looks like it was the briefing that was available before the various individuals had been invited, so to give an understanding about the purpose of the meeting, but also who was attending and why, to consider the issue and the scaling up. Is that correct?
Yeah.
And so are you able to help us in terms of moving to this stage? Who was driving this as the key players to move towards something different?
Well, I think that there was a collective feeling that this was the right approach. All countries around the world were considering this. In fact, although we didn't have a domestic testing industry and we didn't have a public health infrastructure, we did have the benefit of a coherent government approach, and we had the NHS. So in some ways, we were ahead of other countries. Downing Street were very ambitious in this area, as were the 8th floor at DHSC.
Thank you. Now, are you able to assist us as to who identified what we know ended up being the players that provided the infrastructure of the mass testing system? So who identified Thermo Fisher, Roche, Cregan, and then we'll see as we go through Amazon, Boots and the like, who identified these significant companies that were going to assist with setting up and scaling up the system?
Well, that list changed over time, to be honest, and different people came in at different times. Roche, for instance, are a great partner for the NHS. They, though, weren't able to provide the supplies we needed to run their machines, so they actually faded away a bit. So it was an ongoing role, and people came to us all the time with fresh ideas. The company that brought the robots, for instance, that helped enable mass testing came in quite late and were very important indeed. So I don't think that there's an easy answer to that. A few of the key players included Sir John Bell, who you've taken evidence from, Aradazai, who was very helpful on the surveillance, Chris Malloy, who has given evidence as well. There was a number of people who were extremely helpful.
Thank you. And the reason why I asked that, Lord Bethell, it's just as we move through this document, plainly there's been some issues raised as to the individuals or the companies that are identified and contracted with to set up this mass testing, and whether it created almost an unfair advantage as who they went to.
No, that's a massive distraction. There is a very close and effective partnership in the life sciences industry between government, universities and the private sector. And that collaboration, that tripartite collaboration, is something that works extremely well for the patient, for research and for creating jobs. In this industry, everyone knows each other. It's a tight-knit, well-organised industry. And the idea that one company over another gets preferential treatment because they happen to know the minister is a misread of how this ecosystem works.
Thank you. Let's move through. We just display all of that page before we move along, because I think it is helpful because it identifies all of those that were contributing on the 17th of March at number 10. Thank you. Can we move, please, through the document? I want to stop next at page 3, please. You can see the agenda and the plan, and stopping at page 3, we see the identification of Roche and Thermo Fisher. Thank you. And then if we go over to page 4, please, we have the attendees at that meeting. And if we could just scroll through.
Sorry, this is the meeting in number 10, is it?
Yes, that's my understanding. If any of this isn't correct, please, Lord,
No,
please say we can move through. Thank you. June Rain, Sharon Peacock, Professor Dame Sue Hill, Matthew Gould, who the inquiry's heard evidence from, Kristen MacLeod, Professor Jeremy Farrow, Doug Gore from Amazon, a representative from Boots and Roche, Thermo Fisher Scientific, Professor Sir John Bell, who you've just referenced, representative from Randox.
Yeah.
Thank you. Now, if we can move then, please, to the next document, because you, following on from this meeting at Downing Street, is it correct, Lord Bethell, essentially overnight created a mass testing strategy?
Yes. So I drafted the document. I'd say that the ideas had been fleshed out amongst a group of people, but it would definitely got put on a piece of paper that night. Yeah.
Thank you. So if we can turn to INQ 55915, I think we see the strategy that you had identified and fleshed out overnight, please. That's INQ 55915. Thank you. I'm not going to go through the detail because I think it's more important what was then established. Lord Bethell, unless there's anything you want to say about the preparation after that meeting overnight to start to create what became the mass testing and the Lighthouse laboratories.
Yeah, I think just two things. Firstly, this document should have been on the server ready to go at the beginning of January. The fact that it wasn't is astonishing to me, and I hope there is one sitting there ready for next time. And secondly, this is actually how things largely played out. This pillar system did essentially work, not without a few bumps, but what it shows is that collectively that partnership between the NHS, government and the private sector did get to the right answer and could provide a good solution. It's just a shame we didn't start earlier.
Yeah, thank you. And Lord Bethell, I'm not going to explore with you issues of capitalisation and what it did for the nation, but I know you've dealt with that in previous modules. Can we then move to the next day, the 18th of March, please? INQ 592585. That's 592585. Thank you. So now we're the 18th of March, and essentially that
Sorry, the from is the...
Sorry.
That's a... Do you know who that's from?
No, I'm
Don't worry, I think
don't have
presumably it's a private
we
office.
can clarify that, and certainly. But if we look essentially, following on from that meeting, there was a creation, would you agree, Lord Bethell, of a testing working group that was now working almost, I think, till May of 2020, that really got the first 4 lighthouse laboratories off the ground.
That's right.
Thank you. If we go over the page, please. Again, we can see essentially the allocation of tasks and roles to individuals. Is there anything you want to say by reference to the actions, Lord Bethell?
Well, I think one thing that was notable about that period, where there was just an enormous amount of goodwill, and I would pay tribute to the private sector companies that brought expertise, they lent in, they brought ambition, and sometimes they just did things off their own back without any remuneration at all, and this partnership was incredibly impressive.
Well, Lord Bethell, we've heard the passionate evidence of Professor Molloy already as to his company and how they lent in.
Yep.
So please know that some fuller context has already been heard. Thank you. Can I then ask, please, if we have this removed from the screen, it's right, isn't it, that one of the partners to bringing this into reality that's not yet been identified is the involvement of Deloitte, who were then assisting in pulling together the various players that we've seen. Can you assist us to why, from your perspective, we've heard that Deloitte were necessary to bring mass testing to fruition?
Yes. So, firstly, they weren't the only consultancy at the beginning. During this very, very busy period, we engaged with, I think, just about every consultancy in the country. And in fact, some tidying up had to be done by officials because they started overlapping with each other. So that the idea that Deloitte were somehow the only and exclusive player is not correct. Secondly, this is how government works. Government is basically a commissioning body on the whole. It doesn't do well to employ large numbers of people. It is better at contracting out to the private sector. That's how a lot of government services are delivered. So it is no surprise. There is no way we could have done a formal recruitment process in order to get the right people in the right place. We needed agility, speed, and expertise, and that can only be found through the private sector. And a firm like Deloitte, and it could have been any others of them, but they happen to be the ones that are good at that kind of lower level public service, manual style delivery. They held the reins, and they also contracted to other parties in a way that, frankly, government procurement systems are not so good at.
Thank you, Lord Bethell. My lady, is that a convenient moment?
Yes, certainly, if that suits you. Lord Bethell, I'm sorry we're going to have to take you over lunch, but you appreciate we have to think of our poor stenographer who coped so well.
Yeah.
I shall return at 1:45.